telephone, Google Mute has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For DUR board member, please reserve the question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And I will leave the meeting to Dr. Kennan.
Good morning, everybody. Welcome out to the February 2024 DUR board meeting. As Noon announced, we do have a quorum, so we will call this meeting to order. You should have all received a copy of the minutes. Are there any questions, comments, recommendations, or changes we need for the minutes from the last meeting? Hearing lovely silence, can we get a motion to approve those minutes?
Move approval.
I'll second. This is Michelle.
All right, we have a motion and a second. So thank you very much. All in favor?
Aye.
Aye.
Any opposed? Perfect. Then the minutes have been approved. Noon, why don't we turn things back to you for any housekeeping that there may be?
Yeah, the housekeeping item we have today is from Neil. Neil, if you.
Good morning, everyone. And Noon, thank you for giving me a few minutes here. My term's up with the board, and before I just didn't want to leave. I wanted to say goodbye and say it's been an honor and a pleasure working with such amazing people. And I've lost track of the time. I know it's been well over a decade, maybe even longer. But before just leaving, I wanted to say goodbye to everyone during the meeting and say thank you. And then I'll hop off.
Neil, thank you. We appreciate your service. You've been involved in this committee. You functioned as a chair in the past, and you've also been part of the state's P&T committee. And so just a big thank you to you. You've made a dedicated service and a lasting commitment that will mean a lot for everybody that's been involved. So thank you very much.
Eric, thank you. And hopefully someday I'll be back. And I know our paths will cross in the valley and everything. And so wish everybody happy and healthy 2024 and look forward to seeing you all soon. Bye, everyone.
Great. Thanks, Neil.
You're welcome. Bye-bye.
Okay, so another item for the housekeeping is we are actively recruiting the other position in the DUR board as well for consumer representative, for farmer representative, and also for a physician to specialize in child psychiatrist. If any of the board member have any reference or referral, please send them my way. I would appreciate that. That's all the housekeeping item today.
Great. Thank you, Noon. With that, we're going to talk about the persistence on Sublocade for opioid use disorder today. So I will turn it over to the University of Utah.
All right, good morning, everyone. The goal of today's presentation is to discuss the retrospective review of Utah Medicaid patient persistence on the buprenorphine extended release injection Sublocade. Opioid use disorder, abbreviated OUD, is a chronic psychosocial addiction disorder that can develop from exposure to prescription or non-prescription opioids and affects approximately 2 million adults and adolescents in the United States as of 2018. People with OUD have a mortality risk 6 to 20-fold higher than the general population. OUD is treatable with psychosocial treatments such as psychotherapy and maintenance medications that have been shown to reduce opioid cravings and in some cases to reduce the risk of overdose and death. The American Society of Addiction Medicine, or ASAM, 2020 guideline recommends methadone, buprenorphine, buprenorphine with naloxone, or naltrexone as maintenance pharmacotherapy for all patients with OUD. Combination therapy with one of these medications and psychosocial treatments is encouraged by ASAM. However, medication should not be delayed if psychosocial treatment is not available. A specific duration of treatment with maintenance pharmacotherapies for OUD is not defined by ASAM, and treatment may continue indefinitely. ASAM does point out that the treatment durations less than 90 days may have limited effectiveness, and that limited research shows that longer durations may improve treatment outcomes. Most pivotal clinical trials for maintenance medications for OUD measured 6-month treatment outcomes. Sublocade, which I will refer to as SURB throughout this presentation, which stands for Sublocade Extended Release Buprenorphine Injection, is FDA indicated to treat moderate to severe OUD in combination with counseling and psychosocial support. It is administered subcutaneously each month with a minimum of 26 days between doses by a healthcare provider. Missed doses should be administered as soon as possible. Occasional delays of up to 14 days may not impact treatment effectiveness. Note that SURB is one of 2 extended-release buprenorphine injections available in the U.S., but our retrospective review is focused on SURB only. SURB is a carve-out medication covered by the fee-for-service benefit, which is currently one of several preferred OUD medication options on the Utah Medicaid preferred drug list. Its use is limited to patients 16 years of age or older with a minimum of 26 days between doses. So the primary objective of this retrospective review was to characterize SURB therapy persistence among Utah Medicaid fee-for-service adult patients 18 years of age or older with a diagnosis of OUD who initiated SURB treatment. Persistence, or the proportion of patients who continue taking SURB consistently, is one way of looking at treatment adherence. Utah Medicaid fee-for-service claims data, such as claims for relevant ICD-10 codes for diagnoses and National Drug Codes or HCPCS codes for medications, were collected over the study period of March 1st, 2021 to February 28th, 2023. Adapting a quality measure for OUD therapy persistence, we performed descriptive analyses to calculate persistence among incident and prevalent users of SURB at different treatment lengths for up to approximately 12 months, allowing for 3 different scenarios for gaps between administered SURB doses. We also calculated the proportion of patients switching to alternative recommended maintenance medications for OUD. These calculations were performed at the individual patient level and at the SURB regimen level, which are unique SURB treatment courses. This figure illustrates time points over the potential duration of SURB treatment at which we assessed SURB persistence or switches to alternative OUD medications. We assessed SURB persistence at treatment lengths of 2, 3, 4, 6, 9, and 12 months among patients who initiated SURB and had continued Medicaid coverage to observe receipt of SURB for the designated treatment length. Persistence rates at each treatment length were calculated by dividing the number of patients with continued claims for SURB at the designated treatment length by the number of patients with observable Medicaid coverage for that treatment length. We assessed switches to an alternative OUD medication, including various non-SURB formulations of buprenorphine, naltrexone, or methadone. The proportion of patients switching was assessed only among patients with a sufficient duration of Medicaid coverage to complete the designated SURB treatment length without discontinuing all but the final SURB treatment course. Persistence and switches were each assessed for 3 SURB treatment gap scenarios, which I'll illustrate on the next slide. This figure illustrates the 3 assessed scenarios for an allowed treatment gap between successive SERBI doses, which is the maximum time in days between doses which could be observed and still be considered as maintaining persistence. Each scenario added an additional number of days to the minimum 31 days between doses to observe the next SERBI dose. In scenario 1, up to 7 additional days were allowed between doses, while for scenario 2 and 3, up to 14 and 30 additional days were allowed, respectively. This means that a maximum of 38 days, 45 days, or 61 days were allowed between successive SERBI claims to maintain persistence for scenario 1, 2, and 3, respectively. So moving on to the results. In our cohort of adult patients identified between March 2021 and February 2023, 1,310 patients had a claim for a diagnosis of opioid abuse or misuse and SERBI. Among patients with the OUD-related diagnosis claim, approximately 7.7% also had a claim for SERBI. This table shows patient-level SERBI persistence rates at the 6 assessed SERBI treatment lengths for 3 scenarios, allowing for the gaps between SERBI doses. For each scenario, the blue column reports the number of patients observable for that treatment length, and the yellow column shows the proportion of those observable patients who persisted on the SERBI for that treatment length. As you can see, persistence rates decline as treatment duration increases. For scenario 1, which had the strictest allowed gap between SERBI doses, persistence rates were 47.5% at 3 treatment months and only 20% by 6 months. By 12 months, only 7.6% of observable patients were persistent. Persistence rates are higher for scenario 2 and 3 compared to scenario 1. However, even for scenario 3, which allowed for the longest duration between SERBI doses, only about 1/3 of observable patients were persistent at 6 months. This table shows the proportion of patients who switched to another recommended OUD medication, including the other extended-release injectable buprenorphine product, for the 3 different allowed scenarios. The leftmost column reports the number of successive SERBI treatment months before the switch. For each scenario, the highest proportion of switches occurred after 1 month of SERBI treatment, corresponding to about 10% of observable patients. Treatment switches decline as SERBI treatment length increases, but overall, few patients discontinuing SERBI switched to another OUD medication. So our descriptive claims-based analysis of Utah Medicaid fee-for-service utilization for up to approximately 12 months of continuous SERBI use suggests that many patients are not achieving minimal benchmark SERBI durations of 3 or 6 months. For the period of March 2021 to February 2023, only 20% of patients with continuous Medicaid eligibility who initiated SERBI persisted for 6 treatments, using the most restrictive allowed gap of up to 7 additional days between the monthly doses. Early treatment discontinuations after the first or second SERBI dose were common, with only 60% of eligible patients receiving the 3rd dose, even when allowing for up to a 30-day gap between SERBI doses. Relatively few patients who discontinued SERBI switched to an alternative ASAM recommended maintenance medication for OUD. Persistence on SERBI in our cohort appears comparable to or worse than rates reported in the medical literature, although persistence rates have been calculated using different methods limiting direct comparability. For example, in one study, the 180-day retention rate for any formulation of buprenorphine using claims from an all-payer U.S. database was approximately 22% each month from January 2016 to January 2022, which is similar to the persistence rate of about 20% at 6 months in our cohort. Higher treatment retention rates have been reported using a cohort in Canada and in clinical trials. Since we assessed persistence using 3 different treatment gap scenarios, we observed that persistence rates are numerically higher when allowing for longer gaps between doses to maintain persistence. While this could be for many factors which was not explored by our review, One possibility is that some patients are experiencing barriers to receiving CERB doses on schedule. Limitations of our descriptive analysis of claims data among adults should be considered when interpreting the results. Claims data may not reflect true utilization, and our persistence analysis did not capture whether patients intentionally discontinue treatment. Importantly, because we used a cross-sectional approach that included both new starts and ongoing CERB treatment at the start of our study period, we may be underestimating true persistence durations for some patients. Moreover, we were only able to calculate persistence rates among patients with sufficient Medicaid eligibility for the CERB treatment duration assessed, so it's possible that persistence rates would be different if we had a complete cohort of patients regardless of Medicaid coverage. Since long-term CERB persistence is generally low and many patients discontinue treatment by 3 months, Utah Medicaid may consider identifying ways to encourage and or facilitate CERB persistence. For example, Medicaid pharmacy could consider reaching out to patients after the first CERB claim, or at least within the first few months, to reinforce adherence to treatment and help address any issues to avoid unnecessary delays in therapy. While our analysis suggests that nearly half of patients discontinue by 3 months, given the observed declines in CERB persistence across up to 12 months of treatment, interventions between the 3rd and 12th dose could also prove valuable for some patients. Utah Medicaid may also consider consulting additional resources or experts for guidance on evidence-based approaches to promote adherence to CERB or medications for OUD in general, since a systematic search and summary of such information was outside the scope of this retrospective review. On page 10 of the report, we provided links to recent reports from the Substance Abuse and Mental Health Services Administration and CDC, which might provide some helpful guidance. Notably, not all factors associated with poor medication adherence can be addressed by insurance providers alone. Ultimately, it's advisable to consider exploring various factors to improve adherence to medications for OUD treatment. Thank you for your time and attention, and please let me know if you have any questions.
All right. Does anybody have any questions for Lauren? I think it's telling data that makes me a little anxious, I think, honestly, but open it up for the group.
If I may just jump in, and thank you very much for that comprehensive review. Many things come to mind. First of all, 60% of relative, treatment adherence seems to me pretty good, actually, given the complexity of the problem, and it is a complex problem. Just looking at medication management, I think that's what we aim for. But I was curious, just thinking about barriers, and if the purpose of this discussion is to think about, are we able to do anything to improve access? So I don't know enough about how we provide these medications to know if there's anything set up in our delivery that actually is a barrier. So trying to follow all of the different time frames and the limitations and the guidances, I'm not sure. So that's a question. Knowing what I do about substance use, and it isn't my primary focus, but I do know some, something about it. If some patients come in and they're highly motivated and they express a strong desire for treatment and they stay in regardless of whether they get counseling or not, right? Other people seem to do better with a lot of coaching and counseling. And then there's those folks who come in and take, one medication dose, and then you don't see them for a while. But if we have limits to, those people who kind of drop in and out, I guess is what I'm getting at. the end of the population, that end of the spectrum of patients who tend to drop in and out. We might do better for them if we didn't have any limits on when they can get dosing, past a certain interval. So my question is, are we putting up any barriers to medication access by the way that the dosing schedules are set? And if not, that's great, because there are those people who don't engage regularly. So that's a question. And I guess the other question I have is, how well tied to the mental health aspects of care is the medication delivery, because that clearly can, increase the success of treatment. So that's the other flip side of the barrier, I guess, for patients who need really comprehensive care. Thank you.
I can address the first part of your question, Dr. Winstein. So currently, Sublocade is a refer product on our PDL, which means it doesn't require any prior authorizations or any specific criteria for the patient to obtain Sublocade. The only requirement on the Sublocade that we have is the pharmacy have to dispense the medication directly to the provider instead of the patient, so that the provider can administer it to the patient in the office setting. The other part is the Sublocade is refillable as 80%, which is the regular control refillable tolerant. So there is no other restriction on refill too soon or too late. Usually, if we receive the call from the pharmacy that is there's something going on with the medications, we allow also like early refill if they have explanations, clinical rationale explanations on the on why they need an early refill. We tend to be linear on that way as well. So in general, any OUD treatment is there's no really barrier access to care to OUD, especially to Sublocade.
Thank you. That makes a whole lot of sense. This would have then, on those late ones, right? On the ones that are having big delays, if they're not coming monthly, they could still show up in the office, or make a contact, and as long as the original prescription hasn't expired, they could still get what's essentially another dose within the refill period.
Correct.
Yeah. Okay. That makes sense. Thank you.
And we would like to thank you, DRC, for researching this topic. We are internally discuss projects that we can reach out to the patients or identify the patient who is struggling to adhere to the medications, so that we can address this in the timely manner. That is something that we discuss at the pharmacy level as a project. And if the projects go through, we will bring it back to the DUR as well.
So Noon, in terms of, I mean, I know how we are with our ACO population, but in terms of fee for service, we run everything through Intermountain Specialty, who, has nurse care managers that reach out to patients, coordinate with the physician's office, make reminder calls and everything else for the patient so that they can continue that treatment. How does that work for fee for service today?
So the Sublocade is carved out to fee for service. So we see all of the claims.
Okay. So you have it all.
Yeah, we have it all. We have all the claim. The Sublocade is carved out to fee for service. So we see all the claim, and we can run the data to identify the patient who within the certain, we haven't planned out the detail, but it roughly will be something similar to ours AMM, antidepressants adherence program that we are having, that identify patient who has refill in maybe a couple months, a couple weeks, that they cannot compliant with the therapy, and we have a pharmacist who can reach out to those patients to encourage them to go back to the clinic to continue the treatment.
So does the state though, can any pharmacy fill Sublocade for the state? Or are you specifically directing these patients to specialty pharmacies that have high-touch services, who are doing a lot of outreach and coordination beyond just, and I understand it has to be sent directly to the physician. So what are the requirements in terms of a pharmacy that can dispense this for a Medicaid patients?
Yeah, Brian can take that question.
We don't have any restrictions on what pharmacies can dispense it. We allow dispensing by any enrolled provider pharmacy. And we also allow for physician administered, so it can be done through medical, HCPCS, buy and bill, or through pharmacy point of sale. We really do have pretty open coverage. The only time we're going to see a rejected claim is if it's a refill too soon. Maybe a 28-day supply and they're filling it at 14 days or something like that.
Yeah, and I think, Brian, and then the only reason I bring that up is sometimes there's advantages for the patients, and I think, benefit sponsors and others to restrict the location that it can be filled simply based on the fact that you have a whole host of other services that are included with that aren't standard in a lot of pharmacies. And this kind of feels to me like one of those where not every pharmacy's set up to accommodate and do the outreach and do all of the follow-up and coordination and everything else. But I also understand that you have your own set of any willing provider requirements, network requirements, and other things. So was just curious about that.
Yeah.
All right. Any other comments? So Noon, I would assume it is the recommendation of this committee, and if anybody disagrees, please let me know, that it is a good idea for the state to move ahead with more pharmacist intervention and outreach to these patients if that is possible.
Yes, and I did mention in the chat just Dr. Adam Gordon, who, we have our program based out of the VA, and that's a big focus for him within the VA, but he's on the university side as well, and is an expert. I don't know if he could be consulted regarding different kinds of outreach, or there could be some collaboration with our VA pharmacists who also administer buprenorphine kinds of programs. Just a thought as you're developing this aspect of the program.
Okay, thank you, Dr. Weinstein. Let's move on. It looks like we have a little bit of public comment. And so first, let's go to Indivor. Jessica J., are you online and ready to comment?
I am online. I'm not providing any public comment. I'm just here in case anyone did have questions in regards to Sublocade.
All right. Is there anyone that has any specific questions for Jessica, who represents Sublocade? Well, Jessica, we appreciate you being online, and if questions. Linda Finch from Biogen. Linda, are you online?
I am. I have testimony for another drug class. Did you want me to go ahead?
We have you next on the agenda, so let's move ahead, and we appreciate that. Brian Larson will time you. You get 3 minutes.
Great, thank you. So my name's Linda Finch. I'm a medical account director for Biogen, the manufacturer of Zurzuvae or zuranolone. Zurzuvae was approved by the FDA on August 4th, 2023 for the treatment of adults with postpartum depression or PPD. It is the first oral medication approved to treat postpartum depression. Zurzuvae is a neuroactive steroid that acts as a positive allosteric modulator of the GABA A receptor. It's taken once daily in the evening for 14 days. It is a Schedule IV controlled substance, and it carries a box warning for impaired ability to drive or engage in other potentially hazardous activities due to CNS depressant effects that can last up to 12 hours after administration. For the sake of time today, I'm going to refer you to the PI for full warnings and precautions, as well as some dosage adjustments for patients with severe hepatic impairment, moderate to severe renal impairment, and for use with strong CYP3A4 inhibitors. Zurzuvae's efficacy and safety were evaluated in 2 phase 3 randomized double-blind placebo-controlled multi-center studies in women aged 18 to 45 with severe PPD. Onset of symptoms was in the 3rd trimester or up to 4 weeks postpartum, but ongoing symptoms could occur up to 12 months in the primary study and out to 6 months in the secondary study. And patients were allowed to be on a stable dose of another antidepressant therapy during treatment. In both studies, women in the Zurzuvae treatment arm experienced statistically significant improvements in their symptoms compared to placebo as measured by the change from baseline on the Hamilton 17 item depression scale, or HAM-D17, meeting the primary endpoint for both studies. And this treatment effect was seen as early as day 3 after 2 doses of Zurzuvae and was maintained 4 weeks following the last dose and was statistically significant at all time points that were measured. I'd like to mention to the committee that the HAM-D17 is a well-validated research tool accepted by the FDA as the gold standard in depression studies, but other validated tools such as the PHQ-9 or Edinburgh Postnatal Depression Scale are commonly used in the clinical care setting, whereas the HAM-D17 is not. Perinatal depression is currently underdiagnosed and inadequately treated, ultimately leading to greater healthcare resource utilization, long-term effects on mothers and their families. And suicide due to perinatal mental health conditions is the leading cause of overall and preventable maternal mortality in the United States. And even mothers with mild to moderate postpartum depression can experience suicidal ideation. Because of this high unmet need, I'm requesting that you add Zurzuvae to the PDL as a first-line option for postpartum depression. And I'm happy to answer your questions. I thank you for your time today.
Thank you, Linda. Does the committee have any questions for Linda? Hey, hearing no questions. We will turn it over to Stephanie. Stephanie, I think, has a proposed criteria for us to look at today. As this goes on, I do apologize. I need to leave just before 8 o'clock to be in the Business and Labor Committee of the Senate meeting this morning at 8 o'clock. So once I leave, Noon will take over for me. So thank you, everyone. Stephanie?
All right. Good morning, everyone. So right now I have our updated draft of our PA for both Zulresso and Zurzuvae. We decided to combine the two because really the recommendations are pretty much the same. It's just that Zurzuvae is more of an oral formulation option as opposed to Zulresso, which is an infusion. So our criteria are that the patient is 15 years of age for Zulresso or 18 years of age for Zurzuvae, according to the package insert limitation. It must be prescribed by or in consultation with a psychiatrist or mental health specialist qualified in the diagnosis and treatment of psychiatric disease. The patient must have a diagnosis of moderate to severe postpartum depression shown with a validated depression assessment scale score, and they must require immediate use of medication. The recommendations saying that this is appropriate for the immediate use of the medication is the reason why we removed what we previously had for step therapy for oral depressants, purely because those are expected to take 6 to 8 weeks to start working, and these are patients who would actually be considered candidates for ECT without these meds. The patient must not be currently pregnant. They must be less than 12 months postpartum per ACOG recommendations. And the provider must include a documented depression treatment plan, including psychotherapy following their treatment with either one of these medications. We did also add the boxed warning under the note section for Zurzuvae. Dr. Weinstein?
Yes, thank you. I'm just thinking about, in clinical practice, most of these patients are going to be being seen by their OBGYN, or bringing their newborn to a pediatrician, right? But in the pediatric setting, I mean, maybe talking to that individual about their own experience, but in their postpartum visit, it's an OBGYN who might be diagnosing the postpartum depression. So I'm just wondering, is this too restrictive? I don't know if folks have other thoughts about, the limitation on the prescribing. Is it practical? I guess is my question. Is it practical to have the patient have to be consulted to a psychiatrist, knowing what the delays might be with getting somebody to a mental health specialist right then? It could take months in the outpatient setting. And I'm thinking that many, most of my colleagues in OBGYN could probably diagnose a postpartum depression. What do other people think?
Dr. Weinstein, this is Michelle. Sorry to be off screen this morning and to be in two places at once. I tend to agree. Can I just ask from our staff where we landed on that specific recommendation related to the psychiatrist? Is that out of some guidance there or?
So we landed on that with comparing other criteria. We also included that as a specialist type based on recommendations from a psychiatrist on our staff. We are definitely open to including an OB-GYN if people think that is appropriate.
There are also family practice physicians who deliver babies and maybe the physician of follow-up as well.
Good point. I was just trying to think about the person who's most likely to see the woman in the postpartum setting and then the delays that might happen in trying to get that person to a mental health professional, just practically speaking. So I would recommend we not make this a requirement, and I see that that Dr. Britton agrees as well.
Is that a motion?
I'll move and just make a second point about it, that we have a requirement, that we retain the requirement to use a validated scale, and that we remove the second bullet. Just trying to think if there's any other wording that we could use there. I don't know if we even need to modify that. Maybe just I'll move that we take out the second criterion there and retain the rest of those criteria for approval.
Second.
Thank you, Dr. Brinton's and Dr. Weinstein's. All in favor to remove the second bullet and reattend the scale.
Aye.
Aye.
Any opposed? Thank you. Motion passed for that. That is concluding our agenda for today. We have a next meeting in March 14th. We already set the topic to be determined. With that, can I have a motion to adjourn?
So moved.
Thank you, Dr. Hoffman. Any second?
Second.
Thank you. All in favor?
Aye.
Aye.
Thank you. Motion passed to adjourn. Thank you, everyone, for coming today. We will see you again next month.
Thank you.
Thank you all.